Hi, my name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Today, we're going to be talking about the gastrointestinal unit. This is part of our 13-part series to help make didactic year a little bit easier and help you to ace your boards. So let's look at the objectives for this unit. As a reminder, this unit is highly weighted on the PANCE and PANRE, so make sure you're familiar with all of these objectives that are listed here. Before we dive into the diseases, I want to do a real quick anatomy review because these are things that they will give you hints in the question on where the pain is located, and you want to use that as a hint to help you formulate your diagnosis. Reminder in the right upper quadrant, this is where we're typically going to see gallbladder and liver disorders. You may also have pain from a duodenal ulcer in that area. Right lower quadrant is going to usually be appendicitis. Left lower quadrant is usually going to be diverticulitis. Then you may have a kind of diffuse abdominal complaint. So something that could be referred pain from pelvic conditions, could be small intestinal disorders, hernias, or inflammatory bowel disease. Left upper quadrant, remember that the stomach and the spleen live in this area. So something like a ruptured spleen, gastric ulcer, or gastritis. And then finally, we have epigastric pain, so kind of esophageal type pain. This could be referred from something like a myocardial infarction. This could be a peptic ulcer that presents in this area or something like an esophageal rupture. So there's your kind of summary slide. Make sure you look for hints in the question to help you formulate that diagnosis. You all have already seen this slide in the hematology unit, but I want to bring it back for this unit because there are some labs in here that can be elevated when we have disorders of the liver and of the gallbladder. So as a reminder, the red blood cell on average has a lifespan of about 120 days before it's chewed up by the spleen. That will release heme, which is then converted with heme oxygenase to produce unconjugated bilirubin. Remember that this is not water soluble. This will be transported by albumin to the site of conjugation, which is the liver. In the liver, the unconjugated bilirubin becomes conjugated through a series of chemical reactions. And remember that the conjugated bilirubin is now water soluble, so we can release that and excrete that from the body. The conjugated bilirubin will be stored in the gallbladder, and then it will be excreted in one of two ways. It becomes urobilinogen, which in the intestines will be converted to stercobilin, and that's what gives our stool that dark coloration. In certain gallbladder disorders, they may describe something called an acolic stool, which is a white colored stool, and that means there's a problem with getting that conjugated bilirubin into the stool. The second way we process this is through the urinary system. So the urobilinogen goes into the kidneys and the urinary tract. Then it's excreted as urobilin, which gives the urine that yellowish coloration. If we have a disorder in this area, they usually describe the urine as a dark coloration or a cola-colored urine. And then finally, we recycle that remaining conjugated bilirubin, becomes the urobilinogen in the portal blood system, and then it's recycled to make new red blood cells. So if we have a problem with unconjugated bilirubin, that's in the liver. If we have a problem with conjugated bilirubin, that's typically going to be gallbladder, can also be pancreas. Let's do a lab review before we dive into the individual diseases. We just talked about bilirubin. Remember that we have unconjugated, which can also be called indirect, and conjugated, which is called direct. Remember that unconjugated is not water soluble, and it will elevate when you have liver disease because that's the place of conjugation. So if you can't conjugate it, that will become elevated. In conjugated, that will be elevated if we cannot excrete it. So if we have a problem with the gallbladder or the pancreas and we cannot excrete that into the feces or the urine. Another highly tested lab is going to be the tumor markers, and there are three that are most commonly tested. Alpha-fetoprotein is a tumor marker for liver cancers. Cancer antigen, CA19-9, is something that will be elevated in pancreatic cancer. Carcinoembryonic antigen, or CEA, will be elevated in colon cancers. For esophageal disorders and colorectal disorders, there's two main imaging tests that we use. If we want to visualize the actual anatomic structures, we're going to use a fiber optic scope. Upper GI, that's called an endoscopy. Lower GI, that's called a colonoscopy. If we think that it might be a motility disorder rather than just an anatomic structure that could be causing the disease, we would do a barium test, which highlights that upper GI tract or lower GI tract so you can watch the peristalsis and see if it's actually a problem with motility rather than just the anatomy. Pancreatic disorders will have two labs that will be abnormal. One is amylase. Remember that this is produced to help us digest carbohydrates. And then lipase, which is produced to help us digest fats. In gallbladder disorders, your imaging test for this one is going to be ultrasound. Ultrasound is highly sensitive and specific for gallbladder disorders. And the nice thing is there's no radiation involved. The HIDA-scan is a specialized test that helps us evaluate how that gallbladder fills and how it empties. GGT and alkaline phosphatase. These may be elevated in certain gallbladder disorders. GGT is gamma glutamyl transpeptidase. Alkaline phosphatase may be elevated in something like cholecystitis or a biliary obstruction. If that disease causes an obstruction and backup, you may also have secondary elevation in amylase if it backs up into the pancreas, or your liver function enzymes, your AST, ALT, if it backs up into the liver. But remember, gallbladder disorders are usually going to be GGT and ALK-Phos. If you have a backup, it can elevate the pancreatic enzyme and the pancreatic labs or the liver labs. Liver disorders are liver function tests. These are going to be AST and ALT. Remember that ALT, a liver test, is most specific for the liver. AST is usually also elevated when you have an elevation in ALT. GGT and alkaline phosphatase may be elevated in these disorders as well. Remember that alkaline phosphatase can also be elevated in bony disorders, things like hyperparathyroidism or bone metastasis. So you want to think about, is this probably GI related if their liver function test or their GGT is elevated? Or if those are normal and you have an elevated ALK-Phos, start thinking about bony etiologies as well. An upper versus a lower GI bleed. This is something that you need to recognize and treat immediately. There is an anatomical structure called the ligament of Treats that helps us to distinguish proximal lesions from distal lesions. So proximal to the ligament of Treats is going to be the esophagus, the stomach, and the duodenum. So we would call this an upper GI bleed. The presentation for an upper GI bleed is going to be hematemesis, bright red blood that they're vomiting. They could also have coffee ground emesis. That means that the blood has come down through the upper GI system. It's been processed by the stomach acid, which kind of turns it into this black coffee grinds looking kind of appearance. Or you may have melena. Melena is dark red stools. That means that that blood has come all the way from the upper GI tract, has been processed through, and then you're seeing this darkest discoloration, this reddest discoloration of the stool. Upper GI bleeds are 5 times more common than lower GI bleeds. If we are distal to the ligament of Treats, which you can see in that picture there, we're talking about the ileum, the jejunum, the colon or the rectum as the site of that bleed. The most common presenting complaint for this one is going to be hematochezia or bright red blood, because that blood has not been processed up through the stomach. So you're not going to have that coffee ground emesis with this one. The blood has not been processed, so it will still be bright red. Physical exam findings that we would see with any type of hemorrhage: hypotension, tachycardia, tachypnea. Remember, those are normal responses to blood loss. If we have an acute bleed, how do we manage that? We want to establish 2 large bore IVs, so usually about 18 gauge needles, and give them a bolus of normal saline to help return some of the water to the pipes if they're hypotensive. If their CBC shows that their hematocrit is less than 30 or hemoglobin is less than 7, we want to transfuse packed red blood cells to restore that. If their platelets are less than 50, we worry about spontaneous bleeds. Or if they have a prolonged PT-PTT, we would give them fresh frozen plasma to immediately reestablish those platelets. If they have nausea and vomiting, we can decompress the upper GI system with a nasogastric tube. You want to determine the location of the bleed, and that's going to be that fiber optic scope, so endoscopy or colonoscopy. Your patient has a poor prognosis for a GI bleed if they're over the age of 65, if they have comorbidities, diabetes, high blood pressure, other uncontrolled diseases. Active bleeding that you cannot figure out the location of. If they're hypotensive, that means that they've lost a lot of blood already. Or if they have a coagulable disorder, so they are hypocoagulable. All right, let's get into our esophageal disorders. And we're going to start off with esophagitis. This is just kind of a non-specific inflammatory process in the esophagus. And this can be caused by a lot of things. But the history on this one, they're going to say, my throat hurts, I have trouble swallowing. So dysphagia, sore throat, they may have a dry cough as well if this is associated with reflux. They may also have hoarseness if they have acid that's bathing those vocal cords. If this is related to candida or thrush, you may actually be able to see thrush in their mouth. GERD or reflux is going to be the most common cause of esophagitis. So you have this bathing of acid of the throat, which is irritating. Candida albicans, if they use inhaled corticosteroids, for example, if they have asthma, that can cause irritation in the throat. Smoking, alcohol, you're going to see that this is a common risk factor for most of the GI disorders. Pregnancy, because you have an increase in abdominal pressure and that pushes the acid up into the esophagus. Also, you have vomiting in pregnancy. Other diseases that have repeated vomiting, like alcoholics or purging eating disorders. Medications that the patient takes without water, anti-inflammatory medications, inhaled corticosteroids. We just talked about that. Remember to remind your patient to rinse out their throat after they've taken that. Bisphosphonate medications are used to treat osteoporosis. If those get stuck in the throat, they're highly irritating to the throat and they can actually cause esophageal rupture. So you want to counsel your patient to take it with a full glass of water and don't lie back down for 30 minutes. You can also have eosinophilic esophagitis, which is an allergic or inflammatory process that affects the throat. Endoscopy is going to be our correct answer choice for this one because we actually want to visualize the anatomic structures here. This is definitive. It will show us mucosal changes, erosions, white plaques if we have candida, erythema, and then a linear type of furrows in the esophagus. Barium swallow, if you think it might be a motility disorder, it's not a wrong answer, but it's not the most definitive answer choice, and that's what we're looking for on the boards. We want to treat the cause of this. So if it's reflux, we treat it with a proton pump inhibitor or an H2 receptor blocker. If it's fungal, we can treat it with nystatin or fluconazole. If they just have a generalized inflammatory process, you can try a round of steroids to see if that helps to alleviate their symptoms. Next, we're going to talk about the esophageal tears. We have Mallory-Weiss and Boerhaave syndrome. Remember, Boerhaave, B is bad. Mallory-Weiss is not as significant as far as mortality as Boerhaave is. In Mallory-Weiss, you can see that top picture there. This is a mucosal tear that occurs at the junction of the lower esophagus and the stomach. This is usually mild hematemesis that they experience after the vomiting, and their physical exam will be normal. We think about epidemiology really for all of these, alcoholics because they have chronic vomiting, purging eating disorders, and pregnancy because those are highly associated with repetitive vomiting. Mallory-Weiss, this is going to be an endoscopy, and that's what you see on this top picture there. That's your definitive diagnostic for a Mallory-Weiss tear. Mallory-Weiss tears are inconvenient. They're self-limiting. If they are not self-limiting, you can use electrocautery, but most of them are self-limiting. Boerhaave, on the other hand, is not good. This is something that can kill them. This is a transmural, so a full thickness tear and rupture of the distal esophagus, and this has a high rate of mortality. For this one, the patient is going to say, yes, I was vomiting, but then all of a sudden I had this severe chest pain when that esophagus ruptures. There's a physical exam finding called Hammond's crunch, and as you're auscultating that area, you kind of hear this crackling sound. They may very quickly develop hypotension depending on how fast that bleed is. Epidemiology is really the same, but typically we see Boerhaave in alcoholics because they have that more forceful vomiting or retching. On chest x-ray, you may see a widened mediastinum. And then on CT, which you can see on this bottom picture there, you're going to see an esophageal rupture. This one has to be treated with an emergent surgery. So remember, Boerhaave, high mortality, Mallory-Weiss, not high mortality. Barrett's esophagus and esophageal cancer. The reason they're on the same slide is that Barrett's esophagus is a precursor to esophageal cancer. In Barrett's esophagus, they're going to have a normal physical exam finding, but they may say that they've had a prolonged history of reflux or GERD. What happens in Barrett's esophagus is you have this chronic acid exposure in that distal esophagus, and so it changes those distal squamous cells to columnar epithelium. And because you have that high rate of cellular turnover, you have a higher rate of developing adenocarcinoma. So we know Barrett's is a precursor to cancer. You want to monitor somebody who has a diagnosis of Barrett's esophagus with an endoscopy every 6 months because you're monitoring for that progression and that potential development of cancer. The way that we treat this is a proton pump inhibitor. Remember, all of your proton pump inhibitors end in prazole, so omeprazole. And the way that I remember these is prazole. Praise the Lord, they work all the time. They're 24-hour active medications to turn off the acid pumps. The H2 receptor blockers, however, end in to dine. So remember, you take them when it's time to dine or time to eat, and they turn the acid pumps off when you're eating. In esophageal cancer, the patient is going to present with dysphagia of solids. If you look at that picture there, you can see that there's a mass that's impeding the progress of the food getting down that esophagus. So dysphagia of solids prior to liquids. And that's an important point because your motility disorders will present with dysphagia for liquids, then solids. So esophageal cancer is solids, then liquids. They may complain about reflux. They can't get their food down. Remember that cancer bleeds, so they may have hematemesis, that bright red blood. We have our secondary things for cancer, so weight loss. If they have that bleed, they may also have melena, because remember, cancer bleeds, and if it's an upper GI bleed, we'll get melena in the stools. They may complain about hoarseness if this is impinging on the vocal cords. Only in advanced esophageal cancer will you see tenderness over the epigastrum. Here's a good board question here. This is typically going to be squamous cell for the etiology if it's a proximal lesion. It will be adenocarcinoma if it's a distal lesion. Why? Because the Barrett's esophagus. That's where we see that distal lesion is the adenocarcinoma. We know that Barrett's esophagus is a risk factor for this. HPV and oral HPV infection is also a huge risk factor for esophageal cancer. So if they had oral sex with somebody who had HPV and then it was transmitted through that upper GI tract. Smoking and alcohol, that's going to be a risk factor for all of this. We see esophageal cancer most commonly over the age of 65, and males are going to be more common for that. For this one, the barium swallow and the endoscopy are going to be important. On barium swallow, look at that bottom picture there. You see this nice wide esophagus and then this skinny area. That's called an apple core lesion. If you bite around an apple, you have like a widened top, widened bottom, skinny area in the middle. So that's an apple core lesion that is associated with a barium swallow. The definitive diagnosis for this is going to be endoscopy plus biopsy, because we want to get that on a cellular level to figure out if it's squamous cell or adenocarcinoma. This is treated with radiation and resection depending on the stage of that cancer. Esophageal webs and esophageal rings. You can see the Plummer-Vinson web on that top picture there, and then the Schottky ring is going to be the bottom picture. The patient will say they have trouble swallowing or getting food down. Why? Because there's something that's in the way of that esophagus. They may say that they have to regurgitate food. They cannot swallow it fully. Physical exam for this will be normal because you can't see the esophagus when you're looking in their mouth. This is benign, so a non-cancerous narrowing of the esophagus. Plummer-Vinson web, remember from your hematology unit, that's associated with chronic untreated iron deficiency anemia. Schottky ring is associated with hiatal hernias or prolonged reflux because it irritates that tissue, and that tissue forms this kind of scar tissue in that area. These are very common. They are diagnosed with either an endoscopy, which is what you're seeing here, or you can do a barium swallow, but the endoscopy is going to be a lot more definitive here to make sure it's not cancer. Treatment for this, the Plummer-Vinson web, if you supplement their iron and they have a very small web, that can get better. Or you may have to do an esophageal dilation if it's pretty advanced. Schottky ring, they're going to go in and dilate that area or stretch the esophagus, as a patient may call that. If it's unresponsive to that, they may have to do a surgical incision to widen that ring. Esophageal varices. This is something that can cause death in patients, especially alcoholics. In esophageal varices, the patient develops these swollen varicose veins in the lower esophagus. They bleed commonly. They are a collateral system of blood flow from the portal venous system. So if somebody has cirrhosis and the blood can't get into the liver, the body develops this secondary collateral blood flow, and that goes up into the esophagus. This is going to be associated with advanced cirrhosis. That's the most common cause of esophageal varices, and that's why it's associated with alcoholics, because alcoholics get cirrhosis. In esophageal varices, like we said, these things bleed, and when they bleed, they can bleed a lot. So the patient may complain about hematemesis, bright red blood. They may complain about melena if it's been processed through the GI tract. If they're having an active bleed, and these things can really bleed heavily, they may have hypotension. Diagnosis, the definitive one is going to be endoscopy. And what you'll see on there is a specific finding called cherry red spots. You can see in that top picture there, those are the sites of active bleeding. Patients who have known cirrhosis, you want to screen them with an endoscopy every 2 years to make sure that they're not developing the esophageal varices, and if they have them, that they're not actively bleeding. You can also do a magnetic resonance angiogram or an MRA, and that will evaluate the entire portal venous system, and it will highlight that they've developed that collateral blood flow. You want to treat these, you want to control blood pressure with a beta blocker, so something like propranolol. You can band them to try to cut off that blood supply. Sclerotherapy can also be helpful to stop the bleeding. A TIPS, a transjugular intrahepatic portosystemic shunt, can shunt the blood away from the esophagus. This is a 15% mortality if they're actively bleeding. So this goes back to that kind of first slide where we talked about upper GI bleeds. This is a cause of upper GI bleeds that you want to identify and treat quickly. So those were your esophageal disorders, not too bad. Let's talk about our stomach disorders now. Gastroesophageal reflux, or GERD, is very, very, very common. 40% of Americans actually have this. And what happens is the stomach acid comes up and it refluxes into the lower esophagus because you have a weak lower esophageal sphincter, an LES. This is worsened by risk factors that we know: alcohol, hiatal hernias, which you can see in that picture there that changes the anatomy, obesity because of increased abdominal pressure, pregnancy because of increased abdominal pressure and the weakening of that sphincter, smoking. Certain medications can also irritate this: beta blockers, bronchodilators, calcium channel blockers, sedatives, and tricyclic antidepressants are known to worsen GERD. The patient is going to present with this typical history here: burning, substernal, postprandial or after eating, epigastric pain. They get this kind of metallic taste in their mouth. They may have hoarseness if that acid is bathing their vocal cords. When they lie flat, they get this kind of dry cough, because when you lie flat, that allows that acid to come up through that weakened sphincter. The definitive test for this is going to be a 24-hour pH probe monitoring in the esophagus. But you may see, just like we said on endoscopy, you may see those changes where they're developing the Barretts esophageal changes. You can also do manometry, which measures the pressure in that lower esophageal sphincter to see if it's working correctly. But your answer for your boards on this one is a 24-hour pH monitor. Treatment for this: there's a lot of counseling points for this. Avoid nicotine, avoid alcohol, peppermint, caffeine, those can worsen this. Chocolate can worsen this, unfortunately. Weight loss will help to decrease that intra-abdominal pressure. Sit up for a while after they eat. Don't go right to bed after a big meal. Elevate the head of the bed. You can buy a wedge pillow. They're about $20 on Amazon, my favorite place to buy things. But they help to elevate that person, so they're not actually having to elevate the head of their bed. If they have one of those fancy beds where they can sit themselves up, that's fine too. But a wedge pillow is relatively affordable. If it's mild, you can treat it with antacids, H2 receptor blockers. Remember, we take those when it's time to dine. If it's severe, you can take a proton pump inhibitor. Remember, those end in prozole, like omeprazole. If it's the hiatal hernia that's causing the problem, that can be surgically corrected, something called a Nissen fundoplication. If we leave this untreated, it can lead to esophageal cancer because of the Barretts. It can also cause asthma exacerbations in patients who have pre-existing asthma, because the acid can cause a bronchospasm. So very common, make sure you know this one. Peptic ulcer disease and acute gastritis. These are on the same slide because they have a lot of similarities. Peptic ulcer disease, let's start with that one. If they have a duodenal ulcer, food tends to make their symptoms better. So they're going to present with this left upper quadrant tenderness. Remember, that's where the stomach is. So left upper quadrant tenderness. If food makes it better, it tells us it's probably a duodenal ulcer, because this stimulates the digestive juices, which buffer the acid in the stomach. If it's a gastric ulcer, food will make this worse because that increases the gastric acid production. They may complain about nausea or belching after they eat. The etiology of an ulcer is that it is a lesion in the mucosa from chronic acid erosion. H. pylori is going to be our most common causative agent for this one. That's a good board question. The most common cause of peptic ulcer disease is going to be Helicobacter pylori infection. You can also have medications like anti-inflammatory. So if they have chronic migraines or they have chronic osteoarthritis, they may be popping these medications very frequently. Those chemicals actually strip the protective mucosa off of the stomach, and so they get these acid erosions. Much less commonly, head trauma can overstimulate the vagus nerve, so they get this high levels of gastric acid production. And then there's something called zollinger ellison. This is a gastrin-secreting tumor that is very, very rare. So what's the best answer for the boards? Helicobacter pylori or medications like anti-inflammatories. Now let's scoot over to acute gastritis here, because both of these share the same diagnostic and treatment. In acute gastritis, they're going to have vomiting, this burning stomach pain, and some kind of recent binge. They say, oh, I went to a bachelorette party or a bachelor party over the weekend. So smoking, alcohol, and cocaine are commonly implicated in acute gastritis. They'll present with that left upper quadrant pain that's tender to palpation. Depending on how much they're bleeding in that gastritis, they may have the melena. But the coffee ground emesis is going to be the more common one on this, because their stomach is bleeding, it's getting churned up in the acid, and then they vomit that out in that kind of black coffee ground emesis. Acute gastritis differs from peptic ulcer disease because it's diffuse stomach and inflammation, not just in one area where you have the erosion. Helicobacter pylori, most common causative agent still on this one, but anti-inflammatories, alcohol, tobacco, cocaine, food poisoning can also cause this. Both of these are diagnosed with an endoscopy plus a biopsy, because you're looking for that Helicobacter pylori. For the H. pylori test, you can do this test, and there's several ways to do it. You can do a stool antigen, a urease breath test, or a serum level, but you must be off any proton pump inhibitors prior to that, because the results will be inaccurate. Treatment for these: proton pump inhibitor, something like omeprazole, clarithromycin, and amoxicillin. You do this for a prolonged course. If they have a severe allergy to that, you can do proton pump inhibitor, metronidazole, and tetracycline. So remember, diagnosis and treatment are the same for both of these, but they'll have a little bit different of a presentation. Gastric cancer. In gastric cancer, it's going to be most commonly adenocarcinoma for this one. So the patient will present with progressive dysphagia, kind of feeling like they're full all the time, belching, they don't feel like eating, they feel like they're full quickly after they eat, so early satiety. They may have that coffee ground emesis, because remember, cancer bleeds, and that's where our stomach acid is. So they don't feel like eating, and then they feel full very quickly. The secondary symptoms associated with this one: weight loss, anterior axillary or supraclavicular lymphadenopathy. Sister Mary Joseph, this is named after one of the nurses that used to treat this, a periumbilical nodule. That's only if it's advanced. So look for lymphadenopathy and a periumbilical nodule only if it's advanced, but most likely non-specific physical findings, weight loss. What causes the adenocarcinoma? Helicobacter pylori. Pernicious anemia can actually put you at higher risk for gastric cancer, because they develop this kind of chronic autoimmune atrophic gastritis, which increases the cellular turnover. People who have chronic gastritis, again, an increased inflammatory process. We know diets that are high in pickled vegetables, salted fish, salt, smoked meats, and nitrites, like we see in Japan, Chile, Iceland. That's why those are higher epidemiology-wise for getting this. Males over the age of 40 are who we usually see this in. Definitive is endoscopy plus biopsy, and that's usually going to be notated in your question as an adenomatous polyp larger than 2 centimeters. CT scan and a PET scan is done for staging to see how advanced this is. A stool hemocult is a non-invasive test that we can do in the office that may or may not be positive with gastric cancer, but it shows us trace amounts of blood in the stool. Treatment for this is excision plus or minus gastrectomy, just depending on the staging, and then chemoradiation depending on the staging. But key points on this one: feeling full too quickly, always feeling full, weight loss, those secondary symptoms, and remember, adenocarcinoma for this one. Zollinger ellison, I mentioned that one earlier. This is a very, very rare type of tumor that's associated with multiple endocrine neoplasia type 1. That's MEN1. We talked about that one in our endocrine unit. In zollinger ellison, they develop a gastrin secreting tumor that's constantly dumping out gastrin. So the stomach starts to secrete and secrete and secrete this gastric acid. The tumor is usually located in the pancreas or the duodenum. And because you have these high levels of acid, you're chronically wearing away that mucosal barrier. So you get mucosal erosion here. This patient will present with recurrent, large, multiple ulcers that are very resistant to any of the proton pump inhibitors or the H2 receptor blockers. They may also have severe GERD with this one. Your diagnostic lab for this one is going to be an elevated serum fasting gastrin. Normally, when you're fasting, that gastrin should be low, but their level will remain high. What you're looking at in this picture here is called a somatostatin receptor scintigraphy. This is the definitive test for this one. In this one, you have radioactive octreotide that will bind to that gastrin and it lights up the tumor so you can see where it is. CT or MRI is used for planning for surgery to remove it. If it's very mild, and we know that's what it is, you can treat it with a proton pump inhibitor. But typically, because these cause these large recurrent ulcers, you want to resect that tumor. Pyloric stenosis, we're talking about children in this one. This is going to be 3 in 1,000 births, and it usually affects Caucasian males. So 30% are going to be firstborn males. This is diagnosed from ages 3 to 12 weeks old because that's when that baby starts eating larger amounts. And so that's when we see the problem. When they eat smaller amounts, we may not notice the pyloric stenosis. So you are going to have in the history this infant that presents with non-bilious vomiting, and it's going to be projectile. The parents say, it may hit the wall behind me because you have such a high pressure here from the backup of the fluid that's trying to get through that pyloric sphincter that the only way it can come out is the way it came in. The infant will be hungry because they're not getting that food through. They may have a failure to thrive. On physical exam, they're going to be dehydrated. They're not getting enough food. So sunken fontanelles, dry membrane, poor skin turgor, decreased urine output, kind of sunken eyes. Here's your exam question. What is the physical exam finding that's associated with pyloric stenosis? A firm olive-shaped mass in the right upper quadrant. That's really important. So a patient that presents with vomiting, firm olive-shaped mass in the right upper quadrant, we're thinking pyloric stenosis. Diagnostic criteria of definitive choice for this one is going to be an abdominal ultrasound, which you can see in the bottom picture here. You'll see thickening of the pyloric sphincter wall and a very narrowed lumen where the food gets through. Treatment for this is a surgery, and this is a pretty minimally invasive surgery. You're in and out. Pyloromyotomy, so they go in and they cut through that pyloric sphincter. So common patient that's projectile vomiting, and we have that physical exam finding that's important on this one. Diabetic gastroparesis. This is a functional disorder where the patient has a decreased sense of distension because of the gastric neuropathy. Those high level of sugars will affect the gastric nerve. So it causes decreased gastrin release. They're not digesting their food as well. A slowed gut transit, and then smooth muscle dysfunction. So decrease in peristalsis. The patient will have a known history of diabetes in the question because this is a functional disorder. So you're looking for history of diabetes, early satiety. They feel full very quickly. They stay full. So postprandial fullness, nausea, bloating, reflux, that food just kind of sits in the stomach and it doesn't move. Physical exam for this will be normal. This occurs in about 30 to 50% of chronic diabetics. Diagnosis for this one, a gastric emptying scan is going to be the most definitive diagnostic criteria because it measures how quickly the stomach can get rid of that food. One of the best ways to treat this is to control the diabetes, maintain strict glycemic control to prevent it from worsening. There are medications called prokinetics. They help to stimulate that peristalsis. So things like Reglan, Propulsid, Motilium. Erythromycin can activate the motilin receptors and increase the emptying time, so help to get the food out of there quickly. Those are your stomach disorders. Let's move on to gallbladder disorders. Cholelithiasis and choledocholithiasis. These are stones that cause obstruction and backup. Cholesterol stones are going to be the most common etiology of this, but they can also be calcium salts, bilirubin, bacteria, and bile sludge. If they become lodged, the most common place for them to become lodged is going to be at the bile duct and the sphincter of Oddi. Things that cause cholelithiasis and choledocholithiasis, if somebody's had some kind of rapid weight loss plan or they've had bariatric surgery, this causes a decreased contraction in that gallbladder. And so what happens is they get this kind of sludge in there and it precipitates out the stones. Chronically high cholesterol can also cause this precipitation of the stones. This is asymptomatic unless you have a duct blockage. And then the patient will present with right upper quadrant pain. It's going to be sharp in nature, colicky, so it comes and goes. The pain is going to radiate to the right scapula. And it will be worse with fatty food. So in the question, look for a cheeseburger meal or a fast food meal that precipitates these right upper quadrant pain that are sharp in nature. If they have blockage, they may develop jaundice because remember, that's the backup of that conjugated bilirubin. Positive Murphy sign. This one's the important one for the exam question. They will have pain in the right subcostal area with palpation when that patient inhales. So you'll do this kind of sharp upper move, and that's called a positive Murphy sign. You're impinging on the gallbladder. Who do we look for in this question? Pregnant women will have a decreased contractility in their gallbladder due to the progesterone in the pregnancy. So pregnant women. There's also the 5 Fs: female, fat, 40, fair, and fertile. So females are more likely. Obesity is a risk factor for this. Over the age of 40 is a risk factor for this. Caucasians are more likely to get this. And then fertile, they've had a lot of children. This occurs in about 15% of Americans, and there's a higher incidence in Hispanic, Northern European, like we just talked about, that fair. And then Pima Indians are a very specific group of people that live in the American Southwest. They have a super high incidence of this in their populations. I doubt you'll ever get a question on that, but if you get a question about Pima Indians, be thinking about this one. Our labs for this one, we talked about these already: an elevated GGT, ALK-Phos, if they're having obstruction and backup, that bilirubin. On ultrasound, you'll see a dilation of the gallbladder and you'll be able to see the stones as well. ERCP is something that we use to both, it can be diagnostic and therapeutic. So you're looking for that stone in the common bile duct. And this is an imaging test that we can use for this. If we think that it's a problem with the gallbladder contractility, we can use that HIDA scan. That will show us that it has dysfunctional filling or dysfunctional emptying. Treatments for this, the oral dissolving agents are not very effective, but those are for people who are non-surgical patients. So ursodiol. Laparoscopic cholecystectomy or robotic cholecystectomy, for this one, you go in and take the gallbladder out. That's going to be the most definitive. If this patient has an obstruction in the common bile duct, that has to be removed with the ERCP. Remember, we said that's diagnostic and therapeutic. So for this one, think right sharp upper quadrant pain, radiates to the scapula, positive Murphy sign, cholesterol stones, the 5 Fs. This one is definitively diagnosed with that ultrasound, and you want to treat it by taking it out. Those are your main points on this one. Cholecystitis. This is coming from biliary stasis, and this can be from GI surgery, sepsis, rapid weight loss, or pregnancy. This causes that sludge effect like you get with the stones, and it traps that bile, and it causes this secondary inflammatory process and then a secondary infection. So in cholecystitis, it's inflammatory process that can lead to secondary infection. So the history is very similar. Sharp, colicky, right upper quadrant pain that radiates to that scapula. It's worse after a fatty meal, so a fast food or a cheeseburger. That can also cause nausea and vomiting. The difference between this one and the one we just talked about, the cholelithiasis, is this one will also have a fever. It's an inflammatory process. It's an infectious process. Excuse me. So that Murphy sign will be positive, but you will also have a fever on this one. For that inflammatory infectious process, you think about guarding. The patient doesn't want to be touched. Or rebound tenderness. When you push down and you let up, that's when they have the pain, is when you let up. So in the history, look for rapid weight loss, GI surgery, pregnancy. We know that that decreases the contractility. All of those can be risk factors for this. The most common cause for the infectious process is going to be E. coli. We know that E. coli is a common flora that's in the gut, but also Pseudomonas, Enterococcus, and Klebsiella can be common agents, but E. coli is going to be your exam choice for this one. 33%, so a third of those with gallstones will go on to develop cholecystitis. That's why we want to remove them, is to prevent this. CBC, because it's infectious, you will see a leukocytosis. You will also have an elevated GGT, alk-phos, conjugated bilirubin because we can't get rid of it. You may see an amylase, AST, and ALT if you have backup. Ultrasound, definitive. You'll see pericholecystic fluid. So look at this top picture here. You see this fluid surrounding the gallbladder. You see a thickened wall because of that inflammatory process. You can nicely see in the picture here the sludge and the gallstones. Treatment for this, fluids, IV antibiotics if they have fever in the leukocytosis, so unison or zosyn, so high-hitting ones, antiemetics to help that nausea and that vomiting, and then cholecystectomy. So the definitive treatment for all of this is to take it out, but you want to treat the potential infection before you do that because you don't want to take out an infected gallbladder and then have that spread. Ascending cholangitis. With ascending cholangitis, this one is emergent. You need to emergently recognize this one. It is infection in the common bile duct that's secondary to obstruction from a stone. And so that's this high pressure pus that's developing in there. Unless you release that, this has a high rate of mortality, 90% mortality if it's untreated. The patient is going to present with right upper quadrant pain. We know it's gallbladder related. Colicky abdominal pain that radiates to the right scapula. So it's very similar presentation to the two that we just talked about. Charcot's triad. You know, if it's triad, you're going to get an exam question on it. Fever, jaundice, and abdominal pain is the Charcot's triad that's associated with ascending cholangitis. Then you have Reynolds pentad. As this progresses and gets worse, you have that fever, jaundice, abdominal pain, but now we're adding hypotension and altered mental status. Both of those we know are red flags that our patient is not doing well. So make sure you know the triad and the pentad. On CBC, they're going to have a leukocytosis. They'll have an elevated GGT, alk-phos, conjugated bilirubin. Ultrasound or CT can be our initial diagnostic for this. But the MRC, magnetic resonance cholangiography, is going to be definitive for this one. This is emergent because it has such a high rate of mortality. So you can do an endoscopic or percutaneous biliary drainage to drain all of that pus out of the common bile duct. IV antibiotics are also important because this is an infection. So you want to identify this quickly and treat this one. This one has a high rate of mortality. So you remember Charcot's triad, Reynolds pentad are important on this one. Sclerosing cholangitis. In contrast to ascending cholangitis, this is not an emergency. This is something that is a gradual, progressive fibrosis of the common bile duct. We don't know what causes this, but we know that it's got some kind of genetic component and some kind of autoimmune component. But as at this time, we don't know exactly what causes this. The patient will present with these gradually worsening symptoms, very different from the ascending cholangitis. So gradual episodic worsening of pruritus because it's the buildup of bilirubin. It makes us kind of itchy. They may have these episodes of right upper quadrant pain, fatigue. These are all kind of non-specific. Steatorrhea or fatty stools happens when it's advanced because you're having no release of that lipase, so you can't digest that lipase, so it comes out into the stools. Physical exam finding, jaundice, that backup of the bilirubin. Weight loss, if it's advanced, you're having malabsorption. You're not releasing that amylase or lipase. So your vitamins are going to be diminished. The KADE, the fat soluble vitamins. You're not absorbing any fats. You're not absorbing any carbohydrates. So weight loss is a physical exam in an advanced person. Hepatomegaly also, if it's advanced. Key epidemiology for this one is that 90% of people have comorbid ulcerative colitis. That's a huge hint in the question if they have that. So comorbid ulcerative colitis, which we know is an autoimmune disorder, and that's why it's associated with this. 10% will have Crohn's disease, but really look for ulcerative colitis in this one. Elevated GGT and alk-phos, these are going to be greatly elevated. So 3 to 5 times the levels of normal. They'll have an elevated conjugated bilirubin because we know it's a problem with the release of the bilirubin. AST and ALT because this is backing up into the liver and it's causing the liver to become diseased. MRCP is going to be the definitive test. This is magnetic resonance cholangiopancreatography. And you'll see multiple strictures and dilations. So look at this bottom picture here. You can see what's circled in purple. You'll see these strictures or these scarring, and then you'll have dilations in the area after that. So that's our definitive diagnostic test. There is no cure and no effective medication for this one. This will cause cirrhosis because of the accumulation of the bile, and it backs up into the liver, and that causes scarring of the liver. That's why you get the hepatomegaly once it's advanced. Prognosis is 10 to 15 years from diagnosis to liver failure. A liver transplant will prolong the survival, but it doesn't cure the disease. 40% of patients who have this will also develop cholangiocarcinoma, which is a type of cancer. And the prognosis once you develop that cancer is only 6 months. So that's one of the leading causes of death in people who have sclerosing cholangitis. Let's talk about our liver and pancreatic disorders. So we'll start with our liver. Liver cancer. We have primary causes and secondary causes of liver cancer. The patient is going to present with right upper quadrant pain. Remember, that's where the majority of the liver lives in the body. Easy bleeding and bruising because the liver is responsible for the development of platelets. On physical exam, jaundice, hepatomegaly, you're having that buildup of bilirubin. Hepatomegaly, why? Because there's a tumor in there. Etiology, so let's talk about primary versus secondary. Primary is going to be hepatocellular carcinoma, and this is going to be due to cirrhosis in 80% of the cases. So that's why cirrhosis can kill you one way, but a lot of people go on to develop cancer of this. Hepatitis B and C are also causative agents for this. NASH, or non-alcoholic steatohepatitis, we'll talk about that in another slide. And then hemochromatosis, which is the buildup of the iron, high levels of iron in the liver. We can also have secondary or metastatic liver cancer. The most common cause for this is going to be your colorectal cancers. Those are closest just by proximity to the liver with the portal venous system. So that's the first place it goes to with the colorectal cancer. But it can also come from breast, renal cancers, and kidney cancers. Males are going to be more common in this one over the age of 60 because they're more common for cirrhosis. On labs, elevated AST, elevated ALT, elevated unconjugated bilirubin, because remember, the liver is the site of the conjugation. So if the factory or the liver's broken, you're going to have those higher levels of unconjugated bilirubin. You want to be screening your patients with cirrhosis every 6 months with that tumor marker, the serum alpha fetoprotein that we talked about on that second slide, and an ultrasound every 6 months to monitor for the progression of this and to screen them for cancer. CT or MRI will be definitive for this one. If you have one lesion, it's going to be a primary cancer, so coming from the liver itself. If you have multiple lesions, that tells us that it was a hematogenous spread from that portal venous system, and now you have all these little seedlings causing their own little tumors there. So that's metastatic cancer, would be multiple lesions. Definitive diagnosis for this is going to be a biopsy. We know that's always our definitive diagnosis. If it's primary, you want to excise it and consider a transplant, but only 5% of patients with this are transplant candidates. 5-year survival, 18% if it's localized. Once it's metastasized, 2%. Lungs are going to be the most common site of metastasis from the liver. So from the liver goes to the lungs. From the colon goes to the liver. If it's secondary, we do chemotherapy because it's spread in the bloodstream already. There's nothing that any one little excision is going to do for this. So chemotherapy, and you want to treat that primary cancer. Cirrhosis. Cirrhosis has a ton of findings and a ton of history that are associated with this. What cirrhosis is it's a gradual fibrosis or scarring of the liver. The most common etiology for that is going to be hepatitis C. The second most common etiology for that is going to be chronic alcoholism. The third most common etiology is going to be hepatitis B. This can also be associated with NASH and hemochromatosis, but I want you to think 1, 2, 3, C, alcoholism, and B. Those are etiology. So let's go through the history. They may present with impotence because of the portal hypertension, hematemesis because they develop the esophageal varices, dementia. These patients have a buildup of ammonia and lactic acid that they can't filter out of the bloodstream, so they get an encephalopathy. Remember that the liver is the site of filtration of the blood. So if we can't filter, all of these things build up in the bloodstream. They may develop bruising easily because they have decreased platelets. Remember, the liver has a huge role in the development of platelets. They may develop itching because of the bilirubin buildup. We can't get it out of the body, and so it starts to get itchy. The next picture, we'll look at some pictures on the next slide here. Gynecomastia or hypogonadism. They have a buildup of estrogen in the bloodstream that can't be filtered out, so they develop these female characteristics. Asterixis or flashing of the hands. When you try to hold their hands straight, they'll kind of flash or beat their hands. This is from the buildup of ammonia in the bloodstream. Xanthomas that occur, these kind of yellowish deposits on the inner eye. That's from the buildup of cholesterol. Jaundice and icterus, these come from the buildup of bilirubin. Remember, bilirubin is kind of that yellowish discoloration. Caput medusa. This is where they develop this collateral circulation in their gut. And so it looks like they have a jellyfish that is implanted underneath their skin. Medusa means jellyfish. So vessels that look like a jellyfish, kind of superficial in that area. Those are collateral veins that develop because of portal hypertension from the backup of fluid from the liver. Muscle wasting, they're malnourished. Terry's nails, they develop this area of decreased vascularity underneath their fingernails. Spider angiomas, these kind of little pinpoint hemorrhages from the buildup of estrogen. Palmar erythema, they get kind of reddish palms due to the buildup of nitrous oxide. Hepatomegaly, why? Because the liver is getting larger because of the scarring. And then ascites is the fluid buildup because you can't filter it through the liver. We talked about the etiology, Hep C, alcohol, Hep B. This is common in ages about 50 to 60 because the majority of this is going to be in an older population because it takes a while to develop cirrhosis. On labs, we'll see a decrease in albumin, erythrocytes, platelets. So anemia is common from this. You'll have an increase in your liver profile. So ALT, AST. You're also going to have an increase in that unconjugated bilirubin because you cannot conjugate it. If you don't know what's causing this, you can do a biopsy, but that's not usually what's done. Remember, you want to do your endoscopy to screen for varices, and you can do a paracentesis to pull off some of the fluid if they have problematic ascites. So you want to look for your viral profiles. Do a viral profile for hepatitis C and hepatitis B. If they have a known history of alcoholism, you don't necessarily have to do a biopsy there. Treatment for this, if they're an alcoholic, you want to slow the progression, but it does not reverse the previous damage by discontinuing alcohol. That's hard to do a lot of times because a chronic alcoholic is how they get this. The ascites you can treat with furosemide or paracentesis to help kind of get that fluid out of the system. The encephalopathy you treat with lactulose because it's a buildup of lactic acid. Lactulose helps to degrade that. The pruritus, we can treat that with cholestyramine that helps to break down the bilirubin. The transplant probability is dependent on their MELD score, Model for End-Stage Liver Disease, MELD score. This calculates the probability of survival if they are going to be on that transplant list. So what's their INR? What's their creatinine? What's their total bilirubin? What are their comorbidities? And do they have drug and alcohol use? They want to make sure that you are the best candidate to get that transplant before they spend that transplant on you while you're still drinking. Let's look at some of these pictures here that we mentioned. So cirrhosis, that's the fibrosis of the liver. Ascites, they get this very large belly full of fluid. Palmar erythema from the buildup of nitrous oxide. This patient is very yellow in appearance. So jaundice and icterus. Icterus is the eyes. The spider angioma from the buildup of estrogen. Gynecomastia from the buildup of estrogen. This is Terry's nails here. You can see that they have this kind of decreased reddish loss of vascularity in the nail bed. And then the caput medusa, you're looking at a CT scan there, and you can see that that's superficial to the muscles in the abdomen. They get this collateral circulation in that area. Viral hepatitis. This has a lot of similar history and physical exam findings as cirrhosis does. We have two different types of viral hepatitis. We have acute and we have chronic. Acute is going to resolve within about 6 months. So the history for this one, anorexia, nausea, vomiting, arthralgia, fatigue, pruritus because of the buildup of that bilirubin, dark urine and pale colored stools because they cannot conjugate the bilirubin. And remember, it's the conjugated bilirubin that has that dark in coloration and the yellow in coloration in the urine. So if you cannot conjugate that, you'll have dark urine and you'll have pale colored stools because you won't have that conjugated bilirubin in there. Chronic will persist past 6 months. This can be asymptomatic. Fatigue, pruritus, myalgia, arthralgia, paresthesias, kind of non-specific findings for that one. On physical exam for acute hepatitis, icterus, jaundice, they're going to be yellow. Right upper quadrant tendinous because you're having an inflammatory process in that liver. Hepatomegaly may also be present. On chronic, No physical exam findings until you're in liver failure, and then you are everything that cirrhosis is. Etiology for this: only 1% of viral hepatitis progresses to fulminant hepatitis, which is where they go into acute liver failure, cerebral edema, and death. So that's a very rare thing, is fulminant hepatitis. So let's go through A, B, C, D, E. These are the different types of viral hepatitis. When you're looking for hints in the question, these are kind of the most commonly tested ones. So A is going to be somebody who's been traveling to a foreign region that has a high incidence to this. This is a fecal oral transmission, so look for poor sanitation. This will only present as acute. So A is always acute. Remember that one. B can be transmitted through any bodily fluid. So sex, childbirth, healthcare workers are high risk for that one. B is going to be an acute presentation as well, but 5% of adults and 95% of infants will progress to become chronic. So B presents as acute, but it can become chronic later. C is a sexually transmitted infection. IV drug use also. Baby boomer generation, because a lot of people had fun in the 60s, and so they recommend screening that baby boomer generation with this. 80% of Hep C is asymptomatic and it will progress to become chronic, so they may not even know that they have it. Remember that hepatitis C puts them at higher risk for liver cancer and cirrhosis later on. Hepatitis D is very rare. This one is associated with IV drug use, but this one needs a co-infection, and that's a good board question. You must have a co-infection with B to get D, and 95% of D is going to be an acute presentation. E is very, very rare. This is a fecal oral transmission, acute presentation only. I would bet $1 million you will never get an exam question on E. So remember, A, foreign travel, always acute. B, any bodily fluid for that one, that's going to be acute. C, cirrhosis and cancer, and that one is going to be chronic. So all of your C's to go together. C, chronic, cirrhosis, cancer. D needs B. Those are your most common tested points about the viral hepatitis. Your liver function tests are going to be elevated. So ALT and AST are going to be 5 times the normal limits. We're going to see that increase in unconjugated bilirubin. Remember, our factory is broken. The liver's not working, so we cannot conjugate that. IgM hepatitis panel, that will give us all of the different antibodies and antigens for this patient, so we know exactly what type it is. So that's the definitive test. Treatment for this: if it's acute, observation and symptomatic care. There's not a whole lot we can do. There are vaccines for A and B. There are not vaccines for the other ones at this time. That's a good board question. You can use things like interferon or ribavirin, viral replication inhibitors. So for chronic B and chronic C, Harvoni was one of the first ones to come out. And this is a prolonged treatment for this, but that can actually cure the chronic B and chronic C. Non-alcoholic fatty liver disease, or NAFLD. I want to make an important point, so let's look at the etiology for this one first. In this disease, it's not alcoholic related, so non-alcoholic liver disease. The liver develops these fatty infiltrates, and there's a triad that's associated with this one. You know it's a triad, you're going to be asked on it. Type 2 diabetes, obesity, and high levels of triglycerides. Those people are at the highest risk for developing non-alcoholic fatty liver disease. There's 2 types of this. Simple steatosis, which is going to be 80%, which is good. It's reversible and it's asymptomatic. It just happens to be there. You found it incidentally. Non-alcoholic steatohepatitis is NASH, N-A-S-H. That's 20% of your non-alcoholic fatty liver disease, but that one can get you into trouble. That one causes inflammation and it causes fibrosis and leads to cirrhosis and cancer. So the good news is just the simple one is the majority and it's reversible. The bad one, the 20%, is the one you really want to watch out for. This is an asymptomatic disease for the majority. It may present with these kind of vaguey right upper quadrant pain, fatigue, malaise, but typically has no symptoms. When it becomes advanced, they can develop hepatomegaly from the cirrhosis. 30% of Americans have this. Why? Because 30% of Americans fit that triad: type 2 diabetes, obesity, hypertriglyceridemia. CT and ultrasound is going to be our definitive diagnostic for imaging. And then if you think it's NASH, then we would do the biopsy for that one. They look different on the cellular structure. There are no approved medications for this one. The treatment for the simple is going to be gradual weight loss, low-fat diet, low-carbohydrate diet, avoid alcohol or anything that could, potentially harm the liver. And then for NASH, the only treatment for that one is going to be a liver transplant. So not a whole lot of treatments for these. Acute pancreatitis versus chronic pancreatitis. These are on the same slide, but I want you to kind of learn the similarities here. In acute pancreatitis, they're going to have an acute presentation. So acute upper quadrant pain that radiates to the left scapula. So remember, right was gallbladder, left is going to be pancreas. So left scapula, it's worse after eating the high-fat food. So look for fast food or cheeseburger in the question. It's worse when the patient lies flat because it stretches out those tissues. It can cause vomiting and diarrhea. The physical exam findings for this one are highly tested on the boards. The Cullen sign, which is a bruise around the belly button. The gray Turner sign, which is a bruise on the flank. This tells us we have internal bleeding, and those are common areas where that blood settles into. Jaundice, fever, hypotension, abdominal guarding, the patient doesn't want to be touched, distension of the abdomen, and decreased bowel sounds. Those are all physical exam findings, but gray Turner and the Cullen sign are specific for acute pancreatitis. What happens in acute pancreatitis is you develop something called a phlegmon. That's edema and necrosis in a small area of the pancreas. That forms a pseudocyst, and then the pancreatic enzymes kind of eat themselves. So the pancreatic enzymes get stuck in this area and they start to auto-digest the pancreas. Here's your board question. The most common cause of acute pancreatitis in males is alcohol. The most common cause in females is going to be gallstones that trap everything in there. Trauma can cause this. ERCP, which we use to get stones out, can cause pancreatitis. The pancreas, I have friends that work in surgery. They say their rules are eat when you can, sleep when you can, and don't mess with the pancreas because it gets kind of angry. So ERCP can actually cause pancreatitis. On CBC, you will see a leukocytosis. You'll have a 3 times increase in your amylase and lipase. Remember, those are the labs that are associated with the pancreas. CT and ERCP can be definitive as far as imaging and diagnostics for this one. Treatment, fluids and antibiotics. So IV fluids, IV antibiotics. 90% of cases of acute pancreatitis will resolve in 1 week. If it's a gallstone that's causing this, you have to use ERCP to remove that. Aspiration can be done if it's persistent. So a pseudocyst or necrosis in that area, you have to aspirate out those contents in order for this to resolve. So acute pancreatitis, let's review those points. Left upper quadrant pain, worse after fatty meals. Cullen sign, gray Turner sign, fever, jaundice. The pancreas is digesting itself, most commonly alcohol in males, most commonly gallstone in females. You'll see a leukocytosis, amylase lipase increase, fluids, and IV antibiotics. Chronic pancreatitis. In chronic pancreatitis, this is fibrosis, so scarring, atrophy, and endocrine failure of the pancreas. And this happens over the course of a while. It's not an acute pancreatitis. So episodes of postprandial abdominal pain that radiate to that left scapula, worse after those high-fat foods. They may develop steatorrhea because they're not absorbing those fats because they cannot secrete that lipase. Decrease in subcutaneous fat. The patient kind of looks wasted. Their eyes are sunken in because they have decreased fat absorption they don't have that amylase. Age 40 to 50, males are going to be more common on chronic pancreatitis. What's the most common cause of this? Well, we know it's fibrosis, atrophy, and endocrine failure, but it's going to be alcohol. And we know that males are more likely to have alcoholism, therefore your epidemiology. People with very, very high levels of triglycerides are also at higher risk for chronic pancreatitis. Cystic fibrosis, autoimmune fibrosis can also cause this. In chronic pancreatitis, the labs are going to be normal. So the amylase is normal, your lipase is normal. The only way you diagnose this one is really CT or an MRC, that magnetic resonance cholangiopancreatography for that one. Treatment for this, stop the insult, stop the alcohol. You can do a duct bypass, that's called a Pusto procedure, or surgical consultation. If you're a primary care PA, you would want to send that to a GI surgeon for surgical consultation and monitoring for that one. Pancreatic cancer. Pancreatic cancer is one of those really sad cancers that's usually way advanced at the time of diagnosis. 75% of your pancreatic cancers will occur in the pancreatic head. That's a good board question there. As that tumor gets bigger, it will kind of block off the common bile duct. And so they don't get those symptoms until it's much bigger and it's much more advanced. Epigastric pain or back pain that's worse at night. This is pretty specific. Dark urine, because we're not releasing that conjugated bilirubin. Acolic stool, that whitish colored stool, because we're not releasing that conjugated bilirubin. Itchy, pruritus, because of the buildup of the conjugated bilirubin. Loss of appetite, depression. This one is more interesting because there's usually a delay in diagnosis. The patient knows that there's something wrong with them, but they usually have a delay in diagnosis because, you know, back pain, nonspecific, epigastric pain, nonspecific. They've probably been told they have reflux. Weight loss, jaundice, icterus. Those are all things that we know when we have a backup of that bilirubin. This is an important one. The Cavassier sign. This is a palpable enlargement of the gallbladder. You should not really be able to feel the gallbladder. But what happens is that tumor blocks the common bile duct, and that causes bile to build up in the gallbladder and to make it enlarged. So because the tumor is blocking the bile, the gallbladder gets bigger. So the Cavassier sign is a palpable gallbladder. We know pancreatic head is the most common. What are the common causes of this? Chronic pancreatitis is 40% of the etiology. Smoking is 30%. Dietary is 20%. And hereditary multiple endocrine neoplasia type 1 is going to be 10% of the cause of pancreatic cancer. Who do we really see this in? Males are more common. Over the age of 65, smokers are much more common for pancreatic cancer. Diabetes, obesity, diet high in high red meats or processed red meats. Remember the tumor marker that we talked about for this one is CA19-9. That's a good board question there. But they may also have an elevation in conjugated bilirubin, alkaline phosphatase, GGT, but tumor marker is going to be the most commonly tested lab for this question. CT scan is going to be definitive for this one, and then a PET scan we would do for staging. The Whipple procedure, you're going in to resect that pancreatic head and resect the tumor, and then chemoradiation for this one. Again, this is usually advanced at diagnosis. This is a very sad one. The prognosis is only about 4 to 6 months from diagnosis to death, depending on the patient as a whole person. If they're a pretty healthy person, you have a longer prognosis. If they're a smoker and drinker, you have a lower prognosis. That's all we have for our first part of this. I want to thank you for joining us. If you're interested in learning more, we have 2 options for you. If you'd like to buy the rest of the review, you'll get a PDF of all of the slides, and that's $20. If you'd like to really master the unit, you'll get the PDF of the slides, part 2 of the video, a clinical pearls matching exercise, because it's all about repetition with this stuff. So all the things that I pointed out that were highly tested concepts, you're just matching. You'll also get a 50-question practice test with answer explanations, and I'll show you what those look like here. Here's an example of your clinical pearls. So you'll see the things that are most important about that topic, and you'll get a drop-down menu. You can take this an unlimited amount of times. We have 2 levels for tests. We have the didactic level, which is a moderate level difficulty, very similar to the test that you'll be taking in class. There's 4 answer choices for those. Anything that you have as a wrong answer choice will be emailed to you so that you can study that. We also have a PANCE PANRE, a difficulty level that's on par with the boards. This will have 5 answer choices and be much more difficult, usually a multi-step question, so not just a 1-part question. These both can be taken once and you'll get the answer choices that you were incorrect mailed to you. I want to thank you for watching this. Please note that the lawyers make me tell you this is not for diagnostic purposes. This is for educational purposes only. And I want to thank you for watching this, and hopefully we'll see you for part 2. Remember that there are other videos out there for all of the other units, so that I hope this was helpful for you, and I'll see you for the other units.